Right, so thank you for the introduction. So we've heard some pretty good talks here today, so I'm going to be touching on histotripsy. We heard some discussion about that earlier. It's not this sort of thermally ablative therapy, it's a mechanically ablative therapy. So histotripsy uses relatively short pulses of just a few cycles with peak positive pressure amplitudes that can be up to an order of magnitude higher than thermally ablative pulses. These pulses are shocked and they induce microbubble cloud formation via shockwave scattering. So there are three forms of histotripsy in here. I'm talking about this sort of shock scattering histotripsy as depicted in these stills from high-speed videography. So histotripsy is currently in a clinical trial to treat benign prostatic hyperplasia, and so we need an effective mean to monitor the treatment progress. This cavitation process is predominantly isothermal, and so we can't rely on our old friend MR thermometry. And so today I'm going to be talking about two potential mechanisms to monitor ablation with histotripsy, hyperechogenicity from these bubble clouds, and then also acoustic emissions or cavitation emissions from these bubble clouds. And so this is all a very in vitro study. So we have a 1 megahertz source, which is mechanically ablating a prostate tissue phantom, after which the phantom is then sectioned and then stained in order to delineate the borders of the ablation zone. During the ablation, we had a standard imaging array with 128 elements that was controlled by a programmable research ultrasound scanner. We use this to look at both the hyperechogenicity and cavitation emissions. So to look at hyperechogenicity, we use a plane wave B mode image, and you can see the hyperechoic bubble cloud here. We use the same imaging array to simply passively detect emissions from the bubble cloud. And what's nice about this is that these acoustic emissions are a nice surrogate for the mechanical action of the bubble cloud, which is ultimately what's responsible for the ablative qualities of histotripsy. We would then beamform these emissions in order to form what's called a passive cavitation image, which is depicted here. So at the University of Constantius Crucius at Oxford University, they call these passive acoustic maps. So at each location in this image, the pixel intensity is proportional to the power of the acoustic emissions, which again is a nice surrogate for the power of the mechanical action of the bubble cloud on the tissue. We would then co-register either our passive cavitation or B mode images with the phantom histology, an example which is shown here. So this is a composite image of the passive cavitation image and the phantom histology. We would then compare the pixel intensity or grayscale value of our passive cavitation or B mode images respectively along an axial slice through the ablation zone of the phantom histology to reduce this to a one-dimensional problem. So the red curve here is the amplitude of the passive cavitation image along this dashed blue line. The gray is the corresponding grayscale value of the B mode image along that dashed blue line, and then this dashed blue line down below is a sort of a binary thresholding of the phantom histology, a value of 1 which indicates that the phantom has been ablated and a value of 0 indicating that the phantom is still intact. We then vary the threshold for either the passive cavitation or B mode image and compute true positive and false positives based on that histology in order to generate these receiver operator characteristics which are shown here. So here we have the true positive rate as a function of the false positive rate for all of the thresholds for the passive cavitation and B mode images. So this dashed black line in the center indicates the 50% point. So if the receiver operator characteristic lies along that line, it means that the imaging modality is no better than guessing in terms of predicting the ablation zone. But what we see is that both imaging modalities are significantly better than that, meaning they both correlate with this mechanically ablative therapy. Moreover, passive cavitation imaging has a higher area under the receiver operator characteristic curve, which means it's a better predictor of mechanical ablation with histotripsy. We can also pull a couple of other statistics from these receiver operator characteristics, the accuracy, sensitivity, and specificity of these imaging modalities. So in terms of accuracy and sensitivity, passive cavitation imaging was significantly better. In fact, in terms of sensitivity, there's roughly a factor of 3 improvement, although the specificity is roughly the same between the two. So in summary, both passive cavitation and B mode imaging were found to significantly correlate with the mechanical ablation with histotripsy, but in terms of predictability, accuracy, and sensitivity, passive cavitation imaging was outperformed B mode imaging. So just as acknowledgments, we'd like to thank our funding sources, including our friends here at the Focus Ultrasound Foundation. Just as a personal note, I will be leaving Cincinnati for sunnier skies in Chicago. So thank you.
Ken, I noticed one thing, and that is that the cavitation continued beyond the focal spot in your presentation.
So I didn't overlay any of the beam profiles here, but this is, it's, do you mean above and below here? Or?
Yes.
Okay, yeah, so that has to do with a limitation of passive cavitation imaging. So for this, let me see. So this is our imaging array, and there's an elongation of the point spread function for that beamforming algorithm, so it sort of smears the cavitation perpendicular to the axis of the imaging array. And this is something that is currently a source of pain and confusion. But we're working on some newer imaging algorithms. So at the University of Oxford, they are implementing what's called the robust cap-on beamformer that tends to reduce that artifact. We're also working on some of our own approaches.
But my main question was, in histotripsy, is the effect of the sound beam going to be beyond the focal point in terms of the cavitation?
I would not expect it to be. Okay. I mean, in general, for histotripsy, cavitation occurs right at the focus.
Okay.